Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video is missed by anybody.
We are kickstarting our oncology module with today's class. All right, I'm going to be sharing with you cervical screening protocols, and I very politely, humbly spoke on my channel regarding the fact that many of you know the cervical screening protocols. You must have heard the terms like AGUS and LCIL and EDCIL and the Bethesda classification basically, and have been going through. It's like now on your tip of your hand that you remember the cytology as the first screening modality, and then depending on this cytology report, you have learned so many algorithms, right? What will you do if it's a AGUS report? What will you do if it's an ASCUS report? What will you do if it's an LCIL? What will you do if it's an EDCIL? Stuff like that, right? Tonight, this class, it's absolutely swirled, okay? It's going to be completely zapped. The whole cervical screening modality has gone through a big change by this NHS 2023 model. I had put up a poll on my channel only because of this reason, because I wanted to know what my students have been doing up till now. Since it's just a month for your examination, I do not want to confuse anybody who knows and who knows it well. See, FOXY is the system that we Indians, this is one of our bodies. We are going through, following the FOXY GCPR. But remember, they are just good clinical practice recommendations. That's not a guideline. And we follow usually the guidelines which are made by the European nations. So now this thing has already started. NHS 2023 is actually the UK guidelines, or let's say UK practice recommendations. Even that's not a typical guideline, but they've already adopted this system of cervical screening, which I'm just about to tell you in the class tonight. And a little bit of introduction is a must, because I don't want anybody who knows FOXY GCPR very well to get confused with tonight's class. So anybody who's very well versed and knows these practice recommendations, the FOXY ones, pretty well, and is having their exams in the next month, please not attend the class because you'll get confused. Yeah, if you're that confident that you will forget the FOXY ones and now, kind of go by this cervical screening protocols which I'm about to share with you, most welcome, right? So this is why I took this poll, and I saw majority of you go by the, FOXY GCPR, which is fine, because India has not yet totally adopted it. Right? Up till now, we've not really adapted to this new version. But sooner than later, we will be doing that, which is why I bring you tonight's class. And like I always do, here is the way I'm going to go for the class. First of all, why do we need a cervical screening? Okay, so we talk about screening protocols. Remember, we are starting with oncology. We are trying all these things. When I talk about pre-invasive lesions, that's the beginning to the next, invasive cancer. So there are many carcinomas, like even for that matter, let's talk about endometrial carcinoma, for which we have endometrial hyperplasia as one of the pre-invasive lesions, right? That finally develops into endometrial carcinoma. But do you have any screening method for endometrial carcinoma? You don't. You know the reason why? Because not a lot of association has been found between the screening modality and its impact in, really preventing that particular cancer. But that's not the case with cervical carcinoma, which is why gynecologists have a huge role to play. We are the people who are going to tell the population that they are at a high risk, especially Indian population, at a high risk of developing cervical carcinoma. And there are beautiful, tests now devised which can detect this carcinoma at a very early stage rather than being detected at a very later stage in which we don't have much to do for the patient. So it goes through a very long process of, going first of all, HPV being positive for a really long time. And then, the cervical CIN pre-invasive lesions being prevalent for a really long time. And then finally it goes on to the invasive carcinoma, cervical carcinoma, right? So we have huge time to cover it, to finally, stop it or detect the cases at a very incipient stage and to treat them there. Which is why I bring to you cervical screening, because that's going to be the first preliminary class before I take on the giant CA cervix. Okay, we're going to be discussing about the CA cervix as well, but before that, we're going to be talking about the pre-invasive lesions, and in that the pre-invasive lesion, the most important, we're going to be talking about cervical screening protocols. Now, I had posted in my channel, on my channel, a couple of important things like pap smear. I posted on my channel. I posted colposcopy on my channel. I also posted about the treatment modalities. Okay, so punch biopsy and wedge biopsy and cold knife conization. All these things are posted on my channel. How many of you had a chance to see and read those things? Okay, they are very, very important, because as you see over here, I have written over here the treatment. Okay, then I spoke about PAPS is also written there, colposcopy is also written there. I have not included those huge lectures in this class tonight, because my emphasis is going to be teaching you the new NHS protocol 2023 regarding the screening of the cervix and the pre-invasive lesions tonight. So which is why I had to cut down the burden of the class, because of which I posted it on the channel. If you've not seen those three, I repeat which ones: pap smear, colposcopy, and the treatment modalities. All these three things, please go ahead and look at that, those three important lectures. I'll not be removing it till finally you are over with the cervical screening module. When I'll remove this class, I'll remove these as well. And they'll go in my live class recording folder. This class with its PPT will go, but those three actually classes are from my regular updated theory course. I have borrowed it from my theory course and put it over here so that it becomes in one continuum and you're able to understand. Now, so the first thing about cervical screening, why do you need a cervical screening? We need a cervical screening because cervical carcinoma is a very slowly growing carcinoma. The tests which are done for cervical screening, they have a very good sensitivity. So we can associate the disease very fast. They're cost effective and they are acceptable. Okay. For example, if I say, let's say that ovarian carcinoma, you can also detect ovarian carcinoma, especially in the high-risk individuals. We keep calling them every year, and you do a ovarian biopsy every time. Do you think it's a cost-effective analysis, or it is the patient going to be very comfortable getting a ovarian biopsy every time? So it's not a very plausible test. But for cervical carcinoma, for the screening of cervical carcinoma, we have cost-effective, highly sensitive, and patient-acceptable methods, which are available in the market and which are very good in getting to understand whether this patient actually has the pre-invasive lesions or not. Plus, it comes with a lot of other tests which help in finding out whether this patient is going towards the high-risk zone or not. So very easy follow-up, very dependable results, and very, very acceptable results, acceptable tests are available for cervical carcinoma pre-invasive lesions, which is why cervical screening is the talk of these bodies when they sit down to study and analyze how to prevent the big burden of carcinomas. Now, do you think that to prevent cervical carcinoma only screening modalities help? We also have vaccination protocol, which I'll be discussing with shortly, about cervical carcinoma. So you must have heard about the HPV vaccine. Now, one thing I want to know from you all, since we are talking so much about now, suddenly the focus of attention has shifted from the cytology to HPV. Can you tell me how much is HPV responsible in percentage to develop cervical carcinoma? Is it 20%? How much HPV in percentage is responsible for development of CA cervix? So is it 70% of the cases are because of HPV, or 20% cases are because of HPV, or 50% cases are because of HPV? I just want to know a quick survey. Let's see what you think. Guys, come on. Okay, somebody says 70. What else? Good, very good. Really want to know what others think. Come on, guys. Yeah, okay, fine. 70, all right. Okay, what else? 70, okay, 70. Most of you are saying 70. So the answer actually is 90. 90% of cases of cervical carcinoma are because of HPV. Now, do you understand why are we suddenly focusing our attention from the cytology to the HPV virus? Earlier on was said that, patients, especially 25 years and younger, they have, have HPV very often. Okay, so going behind just HPV, we are wasting our time and resources, because HPV comes and goes in 25 years. And I'll tell you how they have designed the NHS protocol so that age, is also taken care of. Now, so that means vaccine is also equally important. Then I come to the screening protocols. That means, suppose HPV is positive, then what will we do? Suppose HPV is negative, then what will we do? If suppose HPV is positive and we're going ahead for cytology, what kind of cytology is important? Suppose cytology is normal, but HPV was high risk, then what will we do? So these are screening protocols. The kind of flowcharts that you had earlier for ASCUS and LCL and AGUS and stuff, the similar protocols, similar flowcharts will be there, but here the focus of attention will be HPV. All right. Guys, I think I had already posted one question before, that now what is the in thing for analyzing the cervical carcinoma or the pre-invasive lesions of the cervix, whether we are focusing the cytology anymore, or whether we've taken up HPV now. Our focus has shifted to HPV. So majority of you had answered HPV. That means all of you really know that now the screening modality has shifted from the cytology to HPV, correct? And the reason I've already told you, 90% of the cases of C cervix are because of HPV virus. All right. So then I'll talk about a little bit about colposcopy, and I'll not be talking about how colposcopy is done, or what is the method of acetic acid, what is its effect on the squamous epithelium, what happens in iodine, why do we choose iodine? That's like undergraduate level questions, and I'm sure all the answers you'll get from my material that I had put on my Telegram channel. So you are not missing out on anything. Tonight in this class, we will be focusing on exactly that thing for which I've designed this class. All right. The other things which are also equally important, but will not be covered by me totally, they are already present in the Telegram channel. You've got to be taking a complete bouquet tonight. Everything, not just this class alone, but also certain other accessory things which are also important. Unless you cross those steps, you will not reach at this step. Right? So this step is important so long as you can understand the earlier steps. Guys, I think I've already shared my screen. Can you all see the screen, guys? Just quickly give me a yes, no, whatever. Just, can you see my screen? Okay, Ashish, if you're there, can you just quickly tell me if you can see my screen, which I've shared? Okay, thank you. Thank you so much. All right, then we come to the treatment protocols. I'll not be discussing every treatment protocol, but I'll be telling you exactly when do we need what treatment protocol, and then how do we follow up these patients, correct?